education webinar, Promoting Good Oral Health Can Help Reduce Cancer Risk. It's the tooth. So my name is Dr. Nicolette Suti. I'm a GP in Palmyra who is on the board of the Cancer Council Education Committee, and it's my pleasure to be chairing tonight's meeting. Now, in the spirit of deepening relationships, I would like to acknowledge the traditional custodians and owners of the land, the Whadjuk people from the Noongar Nation, and recognise their continuing connection to land, waters and community. I also pay my respects to their elders and extend that respect to all Aboriginal peoples living and working in the area. For tonight's webinar, we encourage you to ask questions. You can submit your questions via the question and answer function at the bottom of your screen anytime throughout the presentation, and we will discuss them in the last 5 or 10 minutes. An online evaluation survey will be sent around after the event, and we encourage you to complete this so we can continue to improve the education events we provide for you. Now, it is my pleasure to introduce our first speaker, Dr. Amanda van Nieuwen. Amanda is a very accomplished oral medical specialist, adjunct senior lecturer at the University of WA and consultant at Perth Children's Hospital. She is passionate about oral medicine, and her professional roles include co-chair of the Australasian Sleep Association Dental Sleep Medicine Council, college news editor, and an examiner of the Royal Australasian College of Dental Surgeons. And she is also on the board in oral medicine, a board of studies in oral medicine for the RACDS. She is president of Women in Dentistry WA, vice president of the Dental Specialist Society of WA, secretary of the Royal Australasian College of Dental Surgeons WA, treasurer of the International Association for Dental Research in the Perth region, on the board of directors of the J. Radisich Foundation and Uniting Smiles, and on various other committees. She represents her specialty at several multidisciplinary meetings and regularly lectures and teaches. Amanda has received multiple awards and commendations, including a peer review award, an ADA Valuable Service Award, and ADHF Wrigley Community Service Grant for all her work. Her clinical and research interests include oral mucosal disease, orofacial pain, temporomandibular disorders, dental sleep medicine, and paediatric oral medicine. And I don't know how she has time to be here tonight. So I welcome you, Amanda. Thank you.
Thank you for having me. So I'm quite excited to talk about today's one. It's a little bit of a different lecture for me. So let me share my screen and we can start. So thank you very much for the Cancer Council for the invitation to present tonight's lecture to allied health professionals. So we're going to talk about promoting oral hygiene and a little bit about dentistry. So a little bit of the overview, we're going to talk about the mouth-body connection, answering some frequently asked questions about oral hygiene, talking a little bit about oral cancer and oral cancer red flags, and also smoking cessation. And then I'll hand it over to Anne, and she'll be talking to us about some interesting things about diet, which I'm quite excited to listen to actually. All right, so we all know, unfortunately, that the oral health status of Australian children and adults could be better. This is from the Australian Institute of Health and Welfare. Now, the report's actually updated fairly recently. It was updated in March. However, if you can see here, the papers that it was based upon is 2016 and 2019. And what it basically shows is that there's a significant proportion of Australians who have untreated dental decay. In children aged 5 to 10 years, that's 27%. In adults aged 15 years or over, that is 32%. Now, the reason why I actually brought up the date of the studies is that we know that in 2020 to 2021, and probably 2022 as well, around 1 in 8 adults delayed seeing or did not see a dental professional at least once due to COVID-19. So I think there's going to be a little bit of a backlog, particularly in the public system. Now, the mouth-body connection is something that we've known for a long time. It's actually quite interesting. So I found this paper from 2010, and they looked at the association between oral health and frailty and early death in medieval English bodies in a cemetery called St. Mary Graces. And what they actually, so they exhumed all these bodies and they looked at the teeth and dentition. And what they actually found was that the people who had poorer oral health tended to die earlier. They didn't do as well. well. So my apologies to the dentists in the audience, but I'm just going to give a really brief rundown about periodontal disease and dental decay. So if you look there on the photograph, now this is from the paper, that was an example of periodontitis in the right mandible. And this is where there is chronic inflammation of the periodontium, which is the supporting structures of the teeth. And over time, you can get loss of bone. There's an increased gap between the roots of the teeth and the bone. And the end stage of this disease sometimes is that people can actually end up losing teeth from it. Now, if you look at the photograph there on the lower right-hand side, that is an example of dental decay. Now, dental decay really is a type of bacterial infection. So you get cariogenic bacteria, which is bacteria that can cause dental caries, which is what we call dental decay. And these bacteria can metabolize sugars and produce acid that dissolves the hard structures of the teeth. And we've got several layers of the teeth. We've got the enamel, which is the hardest surface on the outside. We get the softer inner dentine and then the tooth nerve. So when you hear about people getting big infections or big toothaches, that's usually when the dental decay or the infection has reached the tooth nerve. And you can see there from the photograph, that's an example of dental caries involving the left maxillary, second and third molar teeth. So we know that poor oral health has been linked to a whole host of systemic conditions, ranging from the brain to the blood to babies and all of that sort of stuff, which I think is very important, and I'm not trying to downplay this. However, the point that I would like to make is that when we're looking at the evidence, there's a big difference between association and causation. So some of you may already know this, but there are papers that show that in summer, there is an increased amount of shark attacks. Now, this actually correlates with an increase in the number of ice creams that have been sold. And I think the answer for this is obvious, right? So if you're a shark and you're looking for someone to attack, obviously you're going to go for the ice cream filled person. No, not really. So the reason why I bring that up is that there is an association there between shark attacks and the number of ice creams. There is a common underlying factor that's probably not being well recognized, which is that it's summertime. So more people are out in the ocean and it's hot, so more people are eating ice creams. But it doesn't mean that eating ice cream will cause you to be attacked by a shark. So when we are looking at these studies, I think it's important to keep in mind that a lot of times we are aware that there's an association, but the true degree of the relationship may not necessarily be known yet. So don't ignore it, but then we also shouldn't overplay or underplay it. We should recognize the evidence for what it is, I feel. All right, so these are some of the statements which I think are true. And I think these sort of reflect or capture our current understanding of what's happening, which is that poor oral health is significantly associated with some major chronic diseases. Poor oral health can cause disability, which is why it's so important that we put the mouth back in the body, which unfortunately I think in some different healthcare systems or in Medicare, it tends to be left out of the body a little bit. A lot of oral health issues and major diseases do share common risk factors, and therefore addressing these common risk factors is a good idea to address both of these. And general health problems may cause or worsen oral health conditions. So if you have a look there at the graphic that I made on the left, we will move through some of this. So cardiovascular disease is the first thing that I would like to talk about. And I think the studies on this actually do show a strong association. And this is something that I think is becoming more well recognized. This is a study that I found, and I thought that the numbers were surprising to me, actually. And I thought that it would be something that is nice and easily digestible by patients or your friends or family. So a person with fewer than 10 of their own teeth remaining is actually 7 times more likely to die of coronary disease than someone with more than 25 of their own teeth. So some studies have actually demonstrated that the number of teeth can actually be used to assess increased risk of cardiovascular disease in adults. There's also been reports of a linear relationship. So you can actually correlate how many teeth the person has versus the risk of dying from CVD. So there's thought to be a direct link between this. Numbers of existing and new cases of coronary heart disease are also both increased significantly in people with periodontal disease. Now, we don't really understand why this happens. However, there has been a lot of studies looking at this, and there are three main hypotheses or three main groups of hypotheses to explain the consequences of oral infections on systemic diseases such as cardiovascular disease. So one of it is metastatic spread of the infection from the oral cavity resulting from transient bacteremia. So people who have high salivary levels of these types of bacteria, it's thought to also be able to cause a spread of infection. The other one is that the bacteria or the oral microbes can actually produce toxins, and these toxins can actually circulate all around the body, and it can actually cause injury at distal sites to the oral cavity. You can also get inflammation or an ongoing inflammation that is arisen and driven by the body's immune system, which is heightened in response to the oral microorganisms. So periodontal disease, I've showed you the photograph there of the medieval English body there. So about a fifth of the Australian population has been found to have destructive periodontal disease. There is a strong and consistent association between age and the prevalence of periodontal disease. So it's more common in older people. Now, risk factors do include smoking, type 2 diabetes, poor oral hygiene, genetics, immunodeficiencies, and other systemic conditions. So some of the signs and symptoms of periodontal disease include painful gums during toothbrushing, painful chewing, red swollen or tender gums, gums that have pulled away from teeth, and we call that recession of the gingiva, persistent halitosis, which is another way of saying persistent bad breath. You can get pus between the teeth and the gums. You can get tooth mobility, so the teeth become looser and looser, and in its final stages, you can actually lose teeth from them, and people can start to bite differently because their teeth are becoming loose. This here is a dental x-ray. We call this a panoramic radiograph or an OPG, an orthopantogram, and it shows a patient here with periodontal disease. You can see that some teeth are missing. You can see the little bright white line between the two teeth up on the top right-hand side. Those teeth have been glued together because they would be very loose if you look at the amount of bone that is missing around there. And then they also have a periapical abscess and a periodontal abscess. So I'm not sure if you can see my mouse point there, but if you look on the top right side of the screen, which is the patient's upper left on the tooth right at the back, you can see there that there is an area of blackness around the root of the tooth, the bottom, and then also around the side of the tooth. And those are abscesses. The one on the side is called a periodontal abscess because it's an infection involving the supporting structure of the tooth. And the other one at the bottom of the tooth is called the periapical abscess, and that forms around the tooth root when the tooth nerve dies and becomes infected. These are some clinical photographs of patients with periodontal disease showing, recession, a lot of calculus, inflammation of the gingiva. On the bottom right photograph there, you can see that the patient has a little bit of metal that's sticking between their teeth and their gums. That's called a periodontal probe, and dentists and dental specialists who treat periodontal disease, called periodontal specialists, they use these all the time to actually measure how much bone and how much bone has been lost and how much of a gap there is between the tooth and the gum and the bone. Now, apical periodontitis, which is the other one that I was talking about, is where the tooth nerve dies and then it can cause an infection. So if you look there at the photograph or the images on the left-hand side, you can see that the patient has had dental decay, which is the black part in the top white part of the tooth in the enamel. Over time, it's spread and it's infected the inner layer, which is the brown portion called the dentine, and then the tooth nerve. Over time, the tooth nerve becomes irritated and dies. And then there's an infection that reaches the bottom part of the tooth from the pulp that has died. It's commonly a chronic infection, so this takes time to happen. However, it can become infected and become very painful, and that's where we see patients with the classical toothache. Now, people with untreated tooth infections have been reported to be 3 times more likely to have cardiovascular disease than patients who have had treatment of their dental infections. So there is a possible association between cardiovascular disease and apical periodontitis, and by extrapolation, people who have dental decay as well. So this association, we don't really understand why. However, we think that it might be related to a genetic common inflammatory response trait. So there's inflammation and increased inflammation in the mouth and in other areas of the body as well. If you're interested in reading more about cardiovascular disease, this is a very short article. I can give you further references if you want, but this is a recent article that I wrote for a medical forum on the links between dental health and cardiovascular disease. The entire magazine issue is focused on cardiovascular disease, and I think it's freely accessible from their website as well. All right, now let's talk about diabetes, which is another big one. Severe periodontal disease is associated with diabetes, and the relationship is bidirectional. So people with diabetes are more likely to have severe or more difficult to control periodontal disease, and people with periodontal disease are also more likely to have diabetes. Now, periodontal disease in patients who do have diabetes may actually predict the development of end-stage kidney disease. So the studies do show that people with periodontitis, they do have a higher chance of developing pre-diabetes and diabetes. And patients with periodontitis tend to have poorer glycemic status compared to people without periodontitis. Professional periodontal treatment may show a decrease in blood sugar levels, although this effect tends to be short-term, and I don't think there's a very good understanding around why this happens yet. I put a little link there at the bottom on the right-hand side for teeth.org.au. This is the oral health promotion site for the Australian Dental Association, and it's got a few good articles. I think for dentists and allied health professionals alike, if you are looking for information that is accessible to the patient and it's written in plain English so that patients can actually understand it, teeth.org does have a lot of good resources, so I would recommend checking it out. All right, now what other oral conditions can diabetes predispose you to? Higher risk of dental decay or dental caries. There is usually a decrease in saliva production. So you can have the sensation of a dry mouth, which is called xerostomia, or you could have objectively an objective dry mouth, so there's less saliva flow, and that's called salivary gland hypofunction. Also more predisposed to infections such as oral candidosis, and that's the photographs there on the left-hand side. You can see there's a patient there with pseudomembranous candidosis. Looks a little bit like cottage cheese. It does wipe off and leave a red surface underneath. And then the bottom there is a photomicrograph where you can see the Candida species actually invading the epithelium, and the Candida species are the ones that look like little tree branches. Diabetes can also affect healing. So most patients have delayed or poor healing of wounds in the mouth, such as mouth ulcers, and they can also get an altered taste. Respiratory conditions. This is, I think, for most people, probably going to be unsurprising, but improved oral hygiene and frequent professional oral health care reduces the progression or occurrences of respiratory conditions. And this is most particularly seen amongst high-risk elderly adults living in nursing homes, and especially those in intensive care units. Instances of aspirational pneumonia is higher in patients who have dentures, because the dentures obviously collect a lot of bacteria and then they can breathe it in. The risk of pneumonia may be related to the level of oral health, and there is also a weak association between chronic obstructive pulmonary disease, COPD, and oral health. Pregnancy. So maternal periodontal disease is likely associated with premature births and low preterm birth weights. It's not really clear at the moment how treatment of the periodontal disease will reduce the risk of preterm birth. There has also been associations found between mothers with periodontal disease and developing preeclampsia. Other pregnancy-related dental problems, dental caries, dental erosion from morning sickness and the like. And you can also, in response to the change in circulating hormones, you can get these little entities called pyogenic granulomas. Or pyogenic granulomas is the common name, but I don't really like it because pyogenic means that there's pus. There's not actually pus. The more proper terminology, I think, is angiogranuloma, but it's pretty much the same. It means the same thing, where you can get these little swellings or lumps on the gum that grow. You can get them even if you're not pregnant, but they're seen in higher numbers in pregnant women. And that's one there, a photograph of my patient that had it on her palate. Other associations: dementia, stroke, H. pylori infection, obesity, and kidney disease. Unfortunately, it's not within the time of the lecture to go through all of the multitude of systemic conditions, but I hope that you found it interesting. At least this is a little bit of a start there. Now, I'll talk a little bit about oral hygiene because these are some of the frequently asked questions. I think when I get asked questions from members of the public, or when I hang around forums and stuff like that and see what questions are being asked. So first of all, I think a good way to think about brushing is something that's called the modified BAS technique. I was hoping to film a video to show that to you, but I might not be able to. So you may have to look that up, or I can describe it to you. What you really want to do is hold your toothbrush at a 45-degree angle. Rather than doing the back and forth scrubbing motion, it's much better to use a rolling motion. That way the toothbrush bristles can actually penetrate the gum pockets to clean them out. And then this is a lot more gentle on the gum. You should be brushing for at least 2 minutes, morning and night, twice a day, flossing daily. Lots of people like to use mouthwash, and I think that could be a useful tool if you do like to do it. However, it's not mandatory. If you're brushing your teeth adequately and flossing, you shouldn't need to use mouthwash. A common thing, true or false: should you rinse or spit after brushing your teeth? And sometimes I'm surprised that people are surprised about this, but you shouldn't be rinsing your mouth out after you brush your teeth, because you're basically rinsing out all of the good stuff that the toothpaste has left in there. So what you should be doing is brushing your teeth with a piece for an adult, for a pea-sized amount of toothpaste, give it a good brush, and then spit out the excess rather than rinse it all out. This one here is controversial as to whether electric toothbrushes are actually better or not. I think it's personal preference. I think the studies show that if you're cleaning your teeth well, it doesn't matter whether you're using an electric toothbrush or a manual toothbrush. Personally, I like electric toothbrushes a lot better myself, because it kind of takes the thought out of how I'm angling my brush. I feel that the electric toothbrush for me does a better job. But if you're partial to your manual toothbrush, as long as you're doing it well, the studies haven't shown too much of a big difference. And this one here, alcohol-containing mouthwashes may increase the risk of oral cavity cancer. So you may have noticed that maybe about 10, 15 years ago, the mouthwashes that were sold on the market, you would get a few different brands. And then after a few years, they started to release these formulations, and they would have alcohol-free in big letters blazoned across them. The reason for that was that there was actually a few studies that were published, and I think they were actually pioneered by an Australian oral medicine specialist, actually, where they looked at whether it was possible that alcohol, because we know alcohol is a risk factor for developing oral cancer, because alcohol has carcinogens, and it can also increase the penetrance of carcinogens from other things, such as, for example, smoking. They hypothesized that using alcohol-containing mouthwash may increase the risk of oral cavity cancer, and some studies have shown it and some studies haven't, so it's still a bit controversial in the literature. But for something that's not mandatory, say you don't have to use a mouthwash, for long-term use, I would prefer a alcohol-free formulation, or you don't even really have to use it. Okay, now let's talk about the elephants in the room really quickly. Because we do know that one of the barriers sometimes to seeking dental treatment may be the cost. I think the easiest or best way to think about this is if you make an investment in your oral health and you are doing preventative things and getting regular checkups, it is a lot cheaper than having, to rescue a failing dentition later on. So I think using small amounts, being consistent with your dental care usually avoids sticker shock. There are public dental services that are available. Generally, patients will require a healthcare card or a pension card to be eligible to be seen in the public dental system in Western Australia. There is a wait list. However, if there are emergencies, you can generally go to your local public dental clinic, and you can look up where that is online. And you should be able to access subsidized healthcare. Sir Charles Gardner Hospital at the Oral Health Centre Annex Clinic on the ground floor does have emergency clinics that are open on weekends and public holidays. Anyone can go. You don't have to have a healthcare card to attend that clinic. However, there is a cost, so it's not completely free, it's just subsidized. Kids, if their parents receive, I think, tax benefit A or B, or if most people who are eligible, they will know because they will get a letter in their mail. They may be eligible for the child dental benefit schedule, so they do get subsidized healthcare, dental care for kids as well, for eligible kids. All right, now let's move on to the second last part, which is oral cancer. Now, I think when we are treating oral cancer, it's important to think about the process of malignant transformation. So what cancer really is a accumulation of DNA damage and mutations. So if you look here at the photograph, the clinical photographs are probably the one that will be more interesting, where you've got normal tissue progressing to frank cancer. So let's talk about what are some of the oral cancer red flags that may be picked up by a doctor or dentist or allied health professional. But first, let me ask you this question. So true or false, can poor oral hygiene increase your risk of oral cancer? Now, the literature is controversial. However, poor oral health has been associated with an increased risk of oral cancer. And the reason for the hypotheses behind these may include the role of chronic inflammation, predisposing to carcinogenesis, or the process of cancer forming. The other hypothesis may be that by not having good oral hygiene, you're allowing potential carcinogens to stay in your mouth for longer, and then that may cause, more DNA damage and mutations. Now, these are some of the oral cancer red flags. And I think the important one to know is the timeline. So we use 2 weeks because normal mucosal healing in the mouth takes about 7 to 10 days. So if you have an ulcer or a lesion that lasts for longer than 2 weeks, it's important to know why. Now, sometimes it can be as simple as it's not healing because it's subject to trauma all the time, but you want to make sure that it's not healing, that there's a reason why it isn't healing. So ulcers that last for longer than 2 weeks, ulcers that do not have a clear cause are red flags. Localized pigmented lesions of the oral mucosa is a red flag for something like oral melanoma, which does have a poor prognosis. So if the patient suddenly develops a dark spot and you don't know why, in most cases, we would be recommending a biopsy for that. Now, what we look for when we look in the oral cavity in general, we're looking for color and texture changes. So if something looks redder or whiter than the surrounding mucosa, that could be a feature of a potentially malignant disease. Other features include induration or fixation. So what that basically means is that when you touch on the lesion, it's not soft or mobile like the rest of the tissues in the mouth are, and they feel firm. If there are areas of ulcers in the mouth, if they've got rolled margins, that's a potentially worrying feature. That means it's been there for a while. Anything that doesn't heal up. High-risk sites of the mouth as well, we view with an added degree of suspicion. This includes the floor of mouth and lateral tongue. If the patient has numbness or pain for no obvious cause, if their lymph nodes are swollen or even worse, fixed, those are all signs of salivary gland disease. So if they've got non-specific pain or if they've got, swellings in the regions of the salivary glands, you want to be worried in case it is a salivary gland tumor. The other thing that I also talk about is going over the patient's medical history with a fine-tooth comb. Patients who are immunocompromised, we know are at a higher risk of cancer, whether that is because their medications that they're on puts them at a higher risk of cancer, or whether the immunosuppression itself increases their cancer risk. Patients that are medically complex, patients with a self or family history of cancer, or if they have any other signs like fever or malaise or weight loss or systemic signs that don't have a clear cause or is not going away. You may be aware of the Therapeutic Guidelines. There is a version for oral and dental, and this here is a nice summary of the red flag features of oral mucosal disease, and I've already talked about, I think, a lot of these ones. Now, oral candida is an interesting one. This is a candidal infection on the inside of the patient's cheek, and this is chronic hyperplastic candidosis. Now, candida has been hypothesized to be able to metabolize things in your mouth and actually produce carcinogens. So it is controversial, but there is thought to be a possible association between an oral fungal infection by Candida and developing oral cancer. Now, chronic hyperplastic candidosis such as this, it's mandatory to be biopsied because there's a very high chance that these types of lesions are either precancerous or cancerous. Another really important point that I would like to make is not to dismiss the subtle. Sometimes when we think about oral cancers, we think about big, nasty fungating lesions or very obvious signs. Sometimes they can be very subtle. They can happen in young people as well. The studies do indicate that there is a subpopulation of younger people, so under the age of 40, and they tend to be white females as well. The incidence of oral cancer among that population is increasing. So if you find anything that fits those red flag features that we talked about, don't dismiss the subtle. So this here was a oral cancer of the tongue. It doesn't look very exciting, as you can see there, but it is cancer. Now, referral pathways, which is another common question that I get asked, where should you be referring these patients? I think maybe one of the good things to think about first is whether it's cancer or not cancer. If it is definitely, frankly, cancer, I would actually probably suggest referring to a hospital in the patient's catchment area. Oral maxillofacial surgeons, ENT surgeons, plastic surgeons, people who have head and neck training generally will treat cancer. I think where oral medicine specialists like myself come in is if you see a patient with an oral mucosal lesion, but you don't really know what it is, you don't feel that you're equipped to manage it, and you want the patient to get a diagnosis and proper and possible management, I think that's the role of the oral medicine specialist. So, for example, if it's not cancer, but if it's a leukoplakia, like a pre-malignant condition, like a pre-cancer, or a autoimmune condition of the mouth, or an immune-mediated condition like lichen planus, oral medicine specialists tend to be the ones who will follow these patients up long-term as well. But I think in general, the most important, and this is the rule that I go by as well, someone you can call. So someone that you're comfortable with, someone that you can speak to, someone that if you have an urgent patient, you feel comfortable picking up the phone and talking to them about patient and sending them their way. I think that's probably what I would recommend in terms of who you refer to. So someone that you're comfortable with and someone that you know can see the patient quickly and give them good care. All right, last point, smoking and alcohol intake. So we know that smoking and alcohol are big risk factors for developing oral cancer. Even though I've told you about a young white female that's under the age of 40 and in that population, they're more likely to develop oral cancer now, like the incidence is increasing, sorry, that's what I mean. The traditional person who develops oral cancer is still a male who's 60 years and above, who has smoked and drank heavily in their life. Now, alcohol actually is quite a big risk factor for developing oral cancer. However, the big point that I would like to make here is that there is a synergistic effect. So if they consume alcohol, if they're a long-term alcohol consumer and they smoke, there's a fourfold increase in oral cancer risk if the patient consumes alcohol long-term. If the patient is also a heavy smoker, that's a 15-fold increase. So the patients that do both, and I think a lot of them do both, they are at a even higher risk. Now, do we as allied health professionals talk to patients about quitting smoking? These studies are from the University of Sydney and University of Queensland, and they looked at dentists and dental students, and they surveyed them. Now, most dental students out of this population that was surveyed from USyd, they knew that they were expected to give smoking cessation advice. Only 50%, only 45% indicated that they were taught how to do so. 6% felt that it was actually not part of a dentist's role. My argument here that it is absolutely part of a dentist's role because smoking is relevant to so much in the oral cavity as well. In general, the students' confidence to counsel patients was low. The other study there from the University of Queensland, they surveyed dentists, and the top reasons that dentists were not comfortable doing it was that they were afraid that it would cause offense to patients, and then it was followed by a lack of confidence in their ability to provide quit support. Now, dentists really should be talking to patients about tobacco cessation, and these are some of the studies. So patients who received tobacco cessation counseling at the dental office, they were 1.4 times more likely to quit and remain abstinent at 12 months or longer. And that makes sense because dentists see their patients regularly, so we are able to reinforce and provide touch points for these patients. 99% of smokers actually feel that dentists should screen for smoking behaviors, and that your patients actually feel that you're qualified to offer smoking cessation advice. And 80% of them felt that if the smoking was affecting the oral health, then the dentist should be advising them to do so. 50% or 47% of patients felt that they would be motivated to quit if their dentist told them to do so. And this one here I thought was the best, because one of the common arguments is that the dentist doesn't have time to do so. Now, this study here, Watt et al. From 2000, showed that very brief advice lasting less than 3 minutes will help an additional 2% of smokers quit successfully. So it doesn't have to be a very long counseling session. Even brief advice done frequently has been shown to be effective. Now, this one here is an easy way to do it. I just say R. The R stands for ask, advise, and help. If anyone is interested in pursuing this further, I think motivational interviewing is a really interesting thing to look at. It gives you some principles to talk to patients about anything, actually. It's probably useful in all aspects of life. But the general principles are to be engaging, to show empathy, and to evoke a response from the patient in asking why. So you need them to realize what their motivation is in quitting. You want to avoid confrontation, which is one of the common things that sometimes if the patient's not motivated, we don't push it. We make our point, we record it, and then we can check in with them later on. And then the ability to provide support and planning. So the R here, so you can ask the patient if they currently smoke. If they say yes, then you can encourage them to quit. If they are not motivated, then you record what you've done and you can bring it up the next time you see them. If the patient is motivated or they are unsure, then you can provide relevant information. And there are a plethora of resources in Australia that you can provide to the patients, including involving the GP, calling quit line, referring the patient directly. You are able to order resources direct from the government as well to give you brochures that you can have in your practice. So I think all of that is actually really outstanding. Now, if you're interested and you want to do further training, the QUIT does have specific QUIT training for oral health professionals. And if you do it, you can get a little certificate. I think that the Dental Association will be thinking about putting on some training for oral health professionals as well to get a certificate, because this one here, I did it when I was in Victoria, or I did it through ADA Victoria, but ADA WA will be having one soon as well. And this is the important point that I would like to leave, because it's common to get discouraged, especially when patients get very annoyed at you or they feel like you're nagging them. But I think this one here has been really quite motivating for me. 1 in every 33 conversations will actually lead to a patient successfully stopping smoking. So I think that's definitely worth pursuing. Take-home points, we covered a little bit about the mouth-body connection. We talked a bit about some frequent misconceptions. So if you didn't know that you shouldn't be rinsing, you should be spitting, now you know. We talked about some oral cancer risk red flags and also risk factors and smoking cessation. And if you've got any questions that we're not able to cover in this webinar, you're more than welcome to contact me privately or send an email through the Cancer Council WA and they can forward it on to me. Thank you.
Thanks, Amanda. That was fantastic. I think as a GP, we know so little about dentistry, and I think I learned a lot in that hour. That was really useful. Thank you.
Thank you.
And hopefully there'll be some questions at the end. Now, I'd just like to invite our second speaker, Anne Finch. Anne grew up in a household like my poor children, in a tofu and lentils kind of household, and after a brief rebellion working in bars and bakeries, became an accredited practicing dietitian. She is based at the Cancer Council WA and has been working predominantly in public health and chronic disease prevention since 2013. Her expertise is in science communication and developing program messages that are both clear and technically accurate. Recipe development, taste testing, and nutrition analysis are the best part of her job. And now I welcome you, Anne. Thanks.
Hi, everyone. Thanks, Nicolette. And hello, everybody joining us this evening. I will just share my screen. Here we go. Hopefully we are all good to go. Wait up. All right. I find it so strange to speak to my slides. Feels like I'm alone in my room talking to myself, but I will push on. So today I'll be talking to you about the Live Lighter campaign and its connection to oral health and looking at some of the common ground that we have. So on the menu is probably plenty of food puns. First up, I'll give you a little bit of background on what Live Lighter is, how it can help promote oral health, and then just show you some practical resources. So Live Lighter is a social marketing and public health campaign. So that means that basically we have a lot of health promoting ads around. You can see here the phone with the campaign is called Menu App, and that's what's most recently been on TV and buses and billboards and radio and internet ads. And I will show you some of the past campaigns on the next slide. Hopefully some of them will look familiar to you. As part of the Live Lighter campaign, we aim to reduce the burden of nutrition, physical activity, and weight-related chronic disease. And the tools that we use to do that are advocating for environmental changes, encouraging individual behaviour change, and providing practical tools and support to make those changes. So these are some of the previous campaigns. So you can see top right corner, we've got one of our advocacy asks. So you can see they're turning our passion into profit. That's talking about the junk food and alcohol advertising during cricket. Hopefully you'll see there the sugary drinks are a rotten choice advertisement. That's a campaign that we did with ADA WA. And then some of our other ads. So we've got some positive messaging there. So you can see the fruit and veg. We've got a couple of different campaigns that target sugary drinks and then variously targeting alcohol consumption, junk food consumption. And there's another positive one there as well relating to physical activity. So where's the common ground between oral health and the Live Lighter campaign? So this is taking a really kind of clear example of reduction of sugary drinks. And I think there's a few behaviours that we could put there. So perhaps snacking or having a fibre-rich diet are things that both oral health professionals and public health professionals and nutrition professionals would recommend. Reduction of sugary drinks reduces the risk of weight gain, reduces the risk of tooth decay, and both of those things in turn reduce the risk of chronic disease. And you can see there I've also drawn a wiggly line from reducing sugary drinks to reducing the risk of chronic disease, because there is some emerging evidence that certain cancers and other chronic health diseases may be more directly caused by sugary drinks consumption and not just through other disease pathways. So why are we hanging it on sugary drinks all the time? Because they contain no beneficial nutrients and are high in kilojoules. Sugar drinks are the single biggest contributor of sugar to the Australian diet. They're linked to weight gain. And we know that having a high BMI increases the risk of 13 different cancers. And as I mentioned, there's emerging evidence of a link between sugary drinks consumption and cancer, independent of weight gain and body weight. So, as health professionals and as members of society, I think we can all also advocate for changes that are kind of upstream of that individual behaviour change that we're asking people to do, reducing sugary drinks, as part of the social determinants of health model. So the kind of policy changes that I've got up here, regulating the marketing and promotion of sugary drinks, a health levy, which is a more positive way of saying a sugar tax, improving the availability of unsweetened drink options, and limiting the availability of sugary drinks at government facilities are all policy measures that have been investigated and are estimated to be effective at reducing population level sugary drink consumption. So this is something that we can all get behind and will hopefully improve people's long-term health. Now some practical stuff. If you want to promote health and reduce your clients' consumption of sugary drinks, we've got some practical tools. So we've got these posters, we've got that grim teeth one, a more factual, kind of less emotive one of how much sugar is in your drink. People are often surprised. A 600 ml Coke has 16 teaspoons. It's pretty enormous, and we see bigger and bigger drinks than that. Both of these resources and the ones that I'll show you on the next page are available on the Live Lighter website, and I've just taken a screenshot of the places where you can find that. So across the top menu bar, there's Toolbox, and in there is resources. If you click on Toolbox, you'll find it, and you can also go to the For Professionals, Clinical Health Professionals section of the website, and you will find these resources. A few other resources that we have available, which are kind of more teaching tools, I guess, that you could use with clients. We have a goal setting worksheet, and that's based on the principles of motivational interviewing, as Amanda mentioned, a really effective technique for behaviour change. We've also got a wallet card, which is that one that has the trolley on it, and then the advice about the kind of nutrients that you should be looking for, or nutrients of concern rather, on your packaged foods. We've also got an interactive sugary drinks calculator where people can put in their sugary drinks intake, and it will give people an individualized idea of the teaspoons of sugary drinks that they have in a week, how that stacks up over a year, and potential excess kilojoules and possible weight gain related to that sugary drinks intake. So does Live Lighter work as a health promotion strategy? We've recently done economic evaluation of the campaign, and we know that for each year that the campaign runs, we save about 204 health adjusted life years, 3.2 million in healthcare costs. So this is a lot more than the campaign costs to run. So we know that it's an effective preventative health measure. We know that preventative health is kind of the poor cousin of emergency health, and another thing that we can advocate for as health professionals is for more money to go into prevention. So things like screening, public health campaigns, and those kinds of things, cost-effective measures to improve the health of the population. We know that people are drinking less sugary drinks than they used to. So Live Lighter's been around since 2012, and you can see on the left there we've got our baseline data. People who are drinking sugary drinks weekly was 60%. It's now significantly lower at 54%, and you can see that marked against our different phases of the campaign, of the Live Lighter campaign. And we know that our ads are effective at prompting behaviour change. So about a third of people who've seen one of our sugary drinks related ads drank more water, thought more about the harms, and 23% reported drinking less sugary drinks. And that is all for me, and I welcome any questions you guys have. And I've got a few for Amanda as well, so looking forward to it.
Thanks, Anne. That was great. My children, I have twins that are 10, and they've had sugar drink once, and it's when we got married 3 years ago, and it's the best day of their lives. So just show
I
you.
also have twins. They're nearly 4, and yeah, I think the first time they tasted full sugar juice, like I usually dilute it, they were like, What's this juice?
No, thanks. That was great. Now, there's no questions have popped up, but I also have some. I'll let you go first, Anne. You start. Do you have a question for Amanda? Did you say?
I was really interested in the kind of association versus causation of the different chronic health conditions and oral health. What would you say is the one where the line is the most direct between oral health and a kind of more systemic health issue?
Yeah, so I think the biggest two, in my opinion, based on what I've been reading, is cardiovascular disease and diabetes, and then obviously cancer, like oral cancer. There are a few of the others. I think sometimes when we're reading the papers, it is associated, but then I think if we tell people that, for example, periodontitis or periodontal disease is associated with, is associated with cardiovascular, like, for example, to give you an example, so one of the things that I gave was that was that mothers with periodontal disease are more likely to have low-term weight babies, right? But then the interesting thing is that it has not necessarily been shown in the studies that treating periodontal disease will guarantee that none of them will have underweight babies born. Like, so we don't really understand it fully. So the reason that I bring it up is because in many aspects of health, I think sometimes people can misinterpret that and they think like periodontitis caused me to have a miscarriage, whereas that's not really the message. Like it may be associated with this in some conditions, but there's a lot that we don't understand. So I think sometimes when I say these sort of things, I'm a bit worried, and not here, I mean just in general when I lecture, I don't want the message to be that like, that if you don't take care of your teeth, you're going to die of cancer. Like that's not really the message. Like it hasn't caused it, although it may be associated with it. Yeah. So yeah, and I like using the shark and the ice cream one because I think that gives like a parallel that people will understand, right? So it's not because you ate the ice cream, therefore the shark's going to eat you. There was just another factor there in between that like may not necessarily have been realized, which is that it's summertime. So both these things are more likely to happen and they don't directly cause each other.
Amanda, can I ask a question? It's not directly related to anything you've said, but as a GP, we prescribe a lot of medications that cause dry mouth. It would be one of the most common symptoms, and we recommend things to produce saliva. Have you got any tips for us?
Yeah, so it sort of depends. So when I talk to patients about salivary gland hyperfunction, which is dry mouth, if say we are not wanting, like, let's say we know the cause and it is medication related, say it's antidepressant, and the patient has been through a really long journey to get the right dose and the right medication, we don't take them off it, right? So then we manage the symptoms. And then I broadly divide that into salivary stimulating and salivary replacing. So salivary stimulating can be as simple as, having frequent sips of water or chewing sugar-free gum, although sometimes I worry about jaw problems, but something that can stimulate that. Now, that can range from the ones that I talked about to you, or medications. And if it's medications, we can use pilocarpine eye drops that we get them to swallow. Yeah, and that can actually stimulate saliva, but then that has a bunch of side effects. So not many people like it. And it depends on whether they actually have the capacity to produce saliva or not in the first place. So for example, patients that have head and neck radiotherapy and they've got salivary gland hyperfunction as a result of the radiotherapy, there's no point trying to stimulate saliva because the salivary glands aren't working that well. And then in those cases, we talk about replacement products. And I like the oral, I'm not sponsored by them, but I like the Oral 7 products. Sorry, I'm actually still at work, so there you go. So I like the Oral 7 products. So they've got mouthwash, mouth gels, and mouth sprays, and they're basically like a moisturizer for the mouth. The other one that is quite good, no, I don't have any here left. The other one that's quite good is a product that's called Xylitol Melts. Yeah. So xylitol is actually anti-carcinogenic. So it prevents dental decay, and it comes in a little tablet that's brown and white, and you stick the brown side on your gum on the inside next to the parotid ducts. It actually stimulates saliva production. So Xylitol Melts, I find can be helpful, but it's difficult to find. So I usually tell them to go online.
Yeah. Oh, that's useful. Thank you. And do you have any more questions, or does anyone else have a question that they want?
No, but I do have a spruik. If you've got a patient who's having difficulty with xerostomia or dry mouth, when it's one of the really common side effects of a lot of the cancer treatments. And so refer them to a dietitian because we can help.
Oh, actually, this is so good. Can I ask you a question? I'm sorry, I don't want to take up too much time, but I see a lot of head and neck cancer patients, obviously in my job, and a lot of times it's such a fine balance between the fact that they're losing a lot of weight, so they're on very high sugar diet, like the Ensure supplements, or and obviously because they're struggling, so their wife or husband feels bad, or the kids feel bad, they give them ice creams and custards and all of that sort of stuff. And I get it if it's a short-term thing because they're miserable and they're losing weight. But then what tends to happen is that they get a lot of dental decay after, because they have a lack of saliva that is protective for dental decay, and then they have taste changes, or they lose their taste, and they just stay on these very high sugar diets, and it's actually a real struggle to get them back off it. So sometimes what I have suggested is that maybe if they go back to their dietitian and ask for like the diabetic formulation of Ensure and stuff like that, is that something that I should be doing? Because it's very hard to juggle they're losing too much weight but they're getting a lot of dental decay.
Yeah, I guess it really depends on where the patient is and what other side effects they're dealing with.
Yeah.
But you can, so obviously high sugar foods is one way to boost weight, but we can also look at high fat foods.
Yeah.
And so instead of having, say, custard and ice cream, it might be avocado with olive oil on buttered toast or something like that. So we're getting the energy from fat, which is, I guess, better for teeth. And then I guess, promoting good oral hygiene, so rinsing the mouth after those oral supplement drinks. And you can also make your own supplement kind of drinks. So and if you make them milk-based with milk powder, my understanding is that lactose is less cariogenic than other sugars. Is that right?
I think it can still. I think if they're flavored or sugared, I think you still can get dental decay from that. But I mean, I take your point that it's actually quite important to reinforce the oral hygiene, which we do as well. So no, it's good because sometimes I think. Sometimes I think it's really hard for them. I feel for them as well.
Yeah. There's often a lot of competing interests, and what I usually tell my patients, because sometimes there's a misconception in the community, I think, about the sugar feeds cancer. So I speak to a lot of patients who are actively avoiding all sugars, and then also losing weight. So reinforcing that what you're doing now to cope with your treatment and to keep your body strong to cope with the radiotherapy and the chemo is not forever. So you can eat in a way that you don't normally eat, or in a way that feels like naughty or whatever it is, but we can eat for a purpose, and that can be short term, and then once your treatment is over, you can go back to enjoying all the foods that you used to.
Great.
Thank you. That's perfect timing too, right on pretty much time. Thanks, Anne. Thanks, Amanda, for that session. It was really useful. And as we said, everyone to do your evaluation would be great, and everyone can go and enjoy the rest of their evening. Thanks.
Thank you. See you. Bye.
Oh, there is a question here. Oh, it's gone. So good.
That's okay. It was from Emily, who was a dietitian. So she was
okay.
So she was just making a comment there, which I think is good. It's pretty much what you've said as well.
Okay, great. Thank you.
All right. Thank you. See you. Bye.
Bye.
Bye. Great. Should I close it now?
Do we leave? I don't
know.
know.
No, I think you can just leave. Alex, that you don't need anything else, do you?
All good, all good.
Yeah.
Wonderful. All right. Thank you. Thanks,
Thanks.
guys. I had a good time. See you.
See ya.
Bye.
Bye.
Bye.